Welcome to StudyNurseIQ. I'm Jenny, and today we're exploring a crucial topic for both nursing practice and NCLEX success: fluid and electrolyte imbalances. This foundational knowledge will enhance your understanding of patient care and help you excel in your exams. We'll break everything down step by step using helpful mnemonics and practical tips. Let's begin with the fundamentals of body fluid composition. Here's an important fact: the adult human body is primarily water, making up about 60% of total body weight. This varies slightly between males, 60 to 65%, and females, 55 to 60%. Understanding these percentages is crucial for patient care. First key point: ICF, intracellular fluid, comprises 40% of body weight existing within our cells. Second key point: ECF, extracellular fluid, makes up 20% of body weight circulating outside our cells. Here's a vital clinical consideration. Infants and elderly patients need special attention because their unique body composition makes them more vulnerable to fluid imbalances. Now, let's master an NCLEX essential, the 40-20 rule for fluid compartments. Let's break this down clearly. 40% is intracellular fluid found inside cells. 15% is interstitial fluid located between cells. 5% is intravascular fluid circulating in blood vessels. To understand fluid movement between these spaces, we use a simple but powerful mnemonic. V stands for vascularity, blood vessel condition. I for inflammation, tissue response. P for protein, osmotic pressure. S for sodium, electrolyte balance. These four factors work together to control fluid movement between compartments. Keep these in mind as we continue our discussion. Let's examine our first condition: hypervolemia, excess fluid volume. Think of it as too much fluid in the tank. Here's a systematic way to assess hypervolemia using the mnemonic WAIT. Weight gain over 2.2 kilograms in 24 hours, your first warning sign. Edema, noticeable swelling, increased blood pressure, gastric distension, patajugular reflux, trouble breathing. Now, let's understand what causes hypervolemia using another helpful mnemonic: heart. Heart failure, excess sodium, acute renal failure, retention of fluids, too much IV therapy. Treatment focuses on loop diuretics like furosemide, along with fluid and sodium restriction. Your essential nursing assessments include daily weight monitoring, precise intake and output tracking, and regular edema measurements. Now let's examine the opposite condition: hypovolemia, fluid volume deficit. Think of this as running low on fluids. We can remember the causes using the mnemonic "every dog gets so dehydrated." E for emesis, D for diarrhea, G for GI suctioning, S for sweating, D for decreased intake. Watch for these critical warning signs: blood pressure dropping more than 20 mmHg with position changes, heart rate increasing by more than 15 beats per minute, elevated blood urea nitrogen, creatinine and hematocrit, weak and rapid pulse, excessive thirst, muscle cramps and weakness, and decreased urine output. These are your key assessment indicators. Let's review the critical electrolyte normal ranges you'll need to know for the NCLEX. These values are essential for patient assessment. Sodium, 140-45 ml. Potassium, 3 ampifopil. Calcium, 8.5-10 mg per g. Magnesium, 1 of 5 sepsir. Chloride, 98-108 molar. Phosphate, 2.5 to 4.5 milligrams for adults. Let's understand what electrolytes are. They're electrically charged particles essential for body function, divided into positively charged cations and negatively charged anions. The major cations include sodium, primarily found in extracellular fluid, potassium, mainly intracellular, calcium, magnesium, and hydrogen ions. The major anions include chloride, mostly extracellular, bicarbonate, phosphate, primarily intracellular, sulfate, and protein-bound ions. We measure electrolytes in milliequivalents per liter, L, which indicates their chemical activity in the body. Here's a crucial concept: sodium is our primary fluid regulator. When sodium levels increase, fluid retention follows. When sodium decreases, fluid levels drop accordingly. An important safety note: while potassium is mainly inside cells, any sudden release into the blood, such as from trauma or tissue damage, can be life-threatening. Now, let's master sodium imbalance signs using the mnemonic thirst fast. Thirst, H. Hyperthermia, I. Increased heart rate, tachycardia. R for restless, S for sticky dry, restlessness mucus, S. Sticky dry mucous membranes. T. Tilted blood pressure, orthostatic hypotension. Flushed skin, A. Absent deep tendon reflexes. S for seizures, seizures. These signs are vital for your patient assessments. For treatment, remember that dietary sources like bananas, avocados, and leafy greens help regulate sodium. When treating imbalances, hypernatremia requires careful free water replacement, while hyponatremia needs gradual sodium correction. Never exceed 12 milliamps per liter in 24 hours to prevent central pontine myelinolysis. Let's focus on potassium imbalances. These require special attention because they directly affect cardiac function. Watch for these specific ECG changes. In hyperkalemia, potassium above 5.0 milliamps per liter, you're dealing with a cardiac emergency. Key interventions: restrict dietary potassium, monitor for peak T waves on ECG, and protect the heart immediately with IV calcium gluconate. Then work to lower potassium using insulin with glucose, sodium bicarbonate, or Kexolate. Severe cases may require dialysis, and loop diuretics help eliminate excess potassium through urine. For hypokalemia, potassium below 3.5 milliamps per liter, monitor the heart closely. Watch for ECG changes including shallow T waves, PVCs, T wave inversion, and ST depression. Replace potassium carefully through oral or IV routes. Remember, never give IV potassium as a push. Encourage potassium-rich foods such as bananas, potatoes, avocados, and oranges. With hypocalcemia, calcium below 8.6 milligrams per deciliter, prioritize airway and muscle function. Treatment includes IV calcium gluconate, increased dietary calcium and vitamin D, and weight-bearing exercise. Monitor the airway carefully due to laryngospasm risk, and keep emergency equipment readily available. For hypercalcemia, calcium above 10.5 milligrams per deciliter, focus on elimination. Address the underlying cause, provide IV fluids, administer Lasix to promote calcium excretion, and consider phosphate to counteract calcium. Encourage movement, maintain adequate hydration, and manage constipation with fiber intake. 2 critical assessment signs to remember: Schwastek's sign, facial muscle spasm when tapping the facial nerve, and Trousseau's sign, carpopedal spasm, both indicate hypocalcemia. For long-term calcium management, incorporate dietary sources like dairy products, fortified juices, and salmon. Always remember, treat the underlying cause first, then supplement as needed. For magnesium imbalances, hypomagnesemia occurs when levels fall below 1.3. Treatment includes discontinuing loop diuretics, encouraging magnesium-rich foods, and administering oral or IV magnesium supplementation as needed. Hypermagnesemia, when magnesium rises above 2.3, can cause respiratory depression, potentially requiring ventilator support. Treatment includes administering calcium gluconate to counteract magnesium's effects, implementing dialysis in severe cases, and using loop diuretics with IV fluids to promote excretion. For phosphorus imbalances, treat hypophosphatemia with IV phosphorus replacement. In cases of hyperphosphatemia, treatment includes phosphate binders such as calcitriol or Amphigel, along with IV fluids and dialysis when necessary. Lastly, for chloride imbalances, treat hypochloremia with sodium chloride or half-normal saline, while hyperchloremia responds well to Ringer's lactate or sodium bicarbonate therapy. Now let's explore 2 common fluid balance disorders: dehydration and fluid overload. Let's begin with dehydration. The fundamental principle is that all body substances become more concentrated. Think of it like making soup. When you reduce the water content, the flavor intensifies. Your body responds similarly. Here's the process. As water levels decrease, sodium concentration rises, potentially leading to hypernatremia. Potassium levels can fluctuate in either direction. During vomiting or diarrhea, potassium levels typically decrease. However, if the patient develops acidosis, potassium levels may rise. Urine changes become apparent, too. Specific gravity increases above 1.030 as the kidneys work to conserve water, resulting in dark, concentrated urine. Another crucial indicator is serum osmolality. It elevates above 295, indicating increased blood concentration. Now let's examine the contrasting condition, fluid overload. Here's a helpful comparison. Imagine adding too much water to juice. Everything becomes diluted. In fluid overload, sodium levels decrease, which can result in hyponatremia. Potassium levels typically fall as well, either from the dilution effect or as a side effect of diuretic therapy. In terms of urine changes, the specific gravity drops below 1.005, indicating the kidneys are actively eliminating excess water, producing dilute urine. Similarly, serum osmolality falls below 275, reflecting the dilution of blood components. Let's reinforce this important contrast. In dehydration, body substances become concentrated, values increase. In fluid overload, body substances become diluted, values decrease. Now let's explore IV fluids. Understanding isotonic, hypotonic, and hypertonic solutions is essential for delivering safe and effective patient care. We'll break this down systematically. Let's examine the common IV solutions you'll encounter in your clinical practice. Beginning with hypotonic solutions, the primary example is 0.45% normal saline. For isotonic solutions, remember these three key options: 0.9% normal saline, 5% dextrose in water, and lactated Ringer's solution. For hypertonic solutions, we have 5% lactated Ringer's, 5% dextrose and 0.45% saline, 5% dextrose and 9% saline, and 10% dextrose in water. Let's understand the clinical applications of each type. Consider hypotonic fluids as your solution for specific fluid losses, such as post-surgical cases or patients experiencing fluid loss through NG suction or vomiting. Isotonic fluids serve as your emergency response solutions, ideal for managing shock, hypernatremia, blood transfusions, resuscitation, or fluid challenges. Hypertonic fluids are your specialized solutions, particularly effective for treating conditions like hyponatremia or hypovolemia. Here's a clear way to understand how these fluids work. Hypotonic fluids increase cellular water content, isotonic fluids expand extracellular space, and hypertonic fluids draw water from cells into the bloodstream. Take a moment to absorb this information. It's fundamental for your NCLEX preparation. Now, let's transition to another crucial topic, the management of electrolyte imbalances. We'll examine each electrolyte individually. Let's explore sodium imbalances. First, hyponatremia occurs when sodium levels fall below 135. Think of it as having too much water diluting the sodium in your body. The treatment approach is straightforward. We restrict water intake, administer 3% sodium solution for severe cases, or provide oral sodium supplements for mild cases. Throughout treatment, careful monitoring of fluid intake and output is essential, along with daily weight checks. Conversely, we have hypernatremia, when sodium rises above 145. This typically indicates dehydration. Treatment requires careful fluid replacement using D5W, oral water intake if the patient can safely swallow, or free water administration through feeding tubes. Daily weight monitoring remains crucial, as it helps us track treatment effectiveness. Now let's examine another vital electrolyte, potassium. In hypokalemia, where potassium drops below 3.5, cardiac function becomes our primary concern. Monitor the ECG closely for characteristic changes: shallow T waves, premature ventricular contractions, PVCs, T wave inversion, and ST segment depression. Potassium replacement must be done carefully, either through oral supplements or IV administration, but never as an IV push. Encourage consumption of potassium-rich foods such as bananas, potatoes, avocados, and oranges. Hyperkalemia, potassium above 5, represents a serious cardiac emergency. Initial steps include immediately restricting dietary potassium and monitoring for peak T waves on ECG. Protect cardiac function with IV calcium gluconate, then focus on lowering potassium levels using a combination of insulin with glucose, sodium bicarbonate, or K-exolate. Severe cases may require dialysis, and loop diuretics can assist in potassium excretion. Let's turn our attention to calcium imbalances. In hypocalcemia, calcium below 8.6, airway and muscle function require close attention. Treatment protocol includes IV calcium gluconate administration, increasing dietary calcium and vitamin D intake, and encouraging weight-bearing exercise. Monitor the airway carefully due to the risk of laryngospasm, and ensure emergency equipment is readily available. For hypercalcemia, calcium above 10, The key strategy is to flush it out. Begin by addressing the underlying cause, provide IV fluids, administer Lasix to promote calcium excretion, and consider phosphate therapy to counteract high calcium levels. Encourage mobility, maintain adequate fluid intake, and address constipation with proper fiber intake. Regarding magnesium imbalances, let's start with hypomagnesemia, levels below 1.3. Your primary interventions include discontinuing loop diuretics, promoting magnesium-rich food intake, and providing oral or IV magnesium supplementation as needed. With hypermagnesemia, levels above 2.3, respiratory function requires careful monitoring as ventilator support may become necessary. Treatment involves administering calcium gluconate to counteract magnesium's effects, potentially utilizing dialysis in severe cases, and combining loop diuretics with IV fluids to enhance magnesium excretion. For phosphorus imbalances, hypophosphatemia requires IV phosphorus replacement, while hyperphosphatemia management involves phosphate binders such as calcitriol or Amphagel, combined with IV fluids and possibly dialysis in severe cases. Regarding chloride imbalances, treat hypochloremia using sodium chloride or half-normal saline solutions and address hyperchloremia with Ringer's lactate or sodium bicarbonate administration. Let's pause for an important reflection. When managing any electrolyte imbalance, always consider these three critical questions. What specific electrolyte is abnormal? How is this imbalance affecting vital organs, particularly the heart, lungs, and brain? And what is the most appropriate and safest correction strategy? Understanding medication effects on electrolytes. Let's explore how common medications affect your patient's electrolyte levels. This knowledge is essential for safe patient care. First, let's look at medications that affect potassium. Some medications can cause dangerous elevations in potassium levels, leading to hyperkalemia. Here are the key medications to watch. ACE inhibitors, such as lisinopril. Potassium-sparing diuretics, like spironolactone. Remember, these medications retain potassium in the body, making close monitoring essential. Conversely, several medications can lead to hypokalemia, or low potassium levels. Loop diuretics, particularly furosemide, Lasix. Thiazide diuretics. Insulin therapy, which moves potassium into cells. Regarding calcium levels, certain medications can cause hypercalcemia. The most common ones are thiazide diuretics, vitamin D supplements. These medications increase calcium absorption in the body. Other medications can decrease calcium levels, resulting in hypocalcemia. Loop diuretics, which increase calcium excretion. Certain anticonvulsants, which affect vitamin D metabolism. Here's your key clinical point. Whenever administering these medications, consider their impact on electrolytes. Changes can develop gradually, but may lead to serious complications, particularly affecting cardiac function. NCLEX success tip. For patients on diuretics or ACE inhibitors, prioritize monitoring potassium and calcium levels and stay alert for ECG changes. Acid-base imbalances. Now let's break down acid-base imbalances in a way that's simple and easy to remember. First, let's understand respiratory. Understanding acid-base balance acidosis. Now let's explore acid-base imbalances in a clear, systematic way. Let's begin with respiratory acidosis. pH decreases below 735 drops. CO2 elevates above 42 below 735. The underlying issue is inadequate ventilation. Your patient can't effectively eliminate carbon dioxide. Common causes include COPD and hypoventilation. Watch for these key clinical signs: tachycardia, elevated respiratory rate, and blood pressure. Mental status changes. Treatment priorities focus on improving ventilation through oxygen therapy, airway clearance, or ventilatory support if needed. Moving on to respiratory alkalosis. pH rises above 745. CO2 drops below 35s. This condition typically results from hyperventilation, commonly triggered by anxiety, pain, fear. Key clinical manifestations include peripheral numbness and tingling, dizziness, lightheadedness. Treatment focuses on normalizing breathing patterns and addressing the underlying cause. Next, let's understand metabolic acidosis. pH falls below 7.35. Bicarbonate decreases below 22. Common clinical causes include renal failure, diabetic ketoacidosis. Key symptoms to watch for include headache, confusion, deep, rapid Kussmaul respirations, which is the body's natural way of trying to eliminate excess acid. The main treatment focuses on addressing what's causing the acidosis in the first place. In severe cases where the pH drops very low, we may need to give sodium bicarbonate to help balance the acid levels. Now let's explore our final acid-base disorder, metabolic alkalosis. You'll see a pH above 745 and bicarbonate levels greater than 26. The most common causes include prolonged vomiting, extended use of diuretics, low potassium levels or hypokalemia. Key symptoms to monitor: nausea, vomiting, dizziness. To treat this condition, we typically give IV normal saline while addressing whatever's causing the alkalosis in the first place. Here's a helpful tip. Whenever you're looking at lab values for pH, CO2, and bicarbonate, always think about how they relate to your patient's breathing and metabolism. First, identify the cause, then plan your treatment approach. Let's review our essential nursing interventions using an easy-to-remember approach, the ABCD method. A stands for airway. This is especially crucial when dealing with fluid overload. B is for breathing assessment. C represents circulation, including IV access and fluid status. D reminds us of drug therapy implementation. Along with these priorities, remember your ongoing monitoring responsibilities. Strict intake and output measurement. Daily weight checks. Vital signs monitoring at least every 4 hours. Now, let's put your knowledge to the test with an NCLEX-style question. You're assessing a patient who presents with significant 3+ pitting edema, audible crackles, blood pressure elevated at 160/90 tax. What should be your first nursing intervention? A. Give the ordered furosemide. Obtain the patient's daily weight. C. Perform a thorough breathing assessment. D. Implement fluid restriction. Take a moment to consider this. Remember your fundamental ABCs. The correct answer is C. Always assess breathing first. This follows our ABC priority sequence. Let's try another practice question. A patient shows classic hypokalemia symptoms: muscle weakness, decreased deep tendon reflexes, and U waves on their ECG. Their potassium level is confirmed at 2.8 milliamps/ml. What's your priority nursing action? A. Start for potassium replacement. Begin oral potassium supplementation. C. Check the magnesium level. Initiate cardiac monitoring. The correct answer is D. Remember this key principle. With any potassium imbalance, your first priority is protecting the heart. Start cardiac monitoring before beginning any treatment. Here's our final scenario. You have a patient with severe hyperkalemia. Their potassium is dangerously high at 7.2 mg/L, and they're showing ECG changes. What's your immediate priority action? A. Administer Kexolate. Give calcium gluconate. C. Begin insulin with glucose. D. Start sodium bicarbonate. The answer is B. Calcium gluconate. This is your priority because it provides immediate cardiac protection from the dangerous effects of elevated potassium. Thank you for joining me today as we explored these essential concepts of fluid and electrolytes for the NCLEX. Let's remember our key takeaways. Master those normal values. Understand which interventions take priority, and always keep patient safety at the forefront of your care. The mnemonics we've learned today will be valuable tools as you continue your NCLEX preparation journey. I look forward to seeing you in our next session, where we'll explore acid-base balance in detail. Keep up the great work. You're building a strong foundation for NCLEX success.